Herkese
Good morning, everyone. Thank you very much, Mr. Chairman, for this very good introductory remark. When we were designing this presentation approximately 2-3 months ago, we were quite excited, and it was really something interesting because each and every one of us has different vocational and professional tendencies, but now we have this common denominator, which is this issue. Of course, we wanted to have Summit with us, but we know that his heart is here. Of course, each one of us, when starting their career, started with different desires or motivation. But then again, it all comes back to us in this very small room with the patient. It is touching in the miracle of the spirit, I think, our profession. I think it's a very good analogy, it's a very good definition, because there is one room and there are two people in that room, and the activities in that room with these two people do alter certain processes in the brain, and we have to understand these processes, what they alter. Of course, as professionals that are engaged in this field, we are kind of convinced with these new advances, but at the same time we have interns, residents that are quite enthusiastic about learning the very fundamentals and learning the very core of these processes. So let me start my presentation.
Şimdi biraz önce odanın içerisinde olup biten durumdan.
I talked about this room and two people in that room. If I have to summarize the literature of psychotherapy, I think this will be the sentence for that by Goethe. Quote unquote, this sentence, human recognizes himself only in human, it summarizes our condition as professionals. And you, I think, all know this person, and he is also an author that we recommend always to our residents. Mr. Wallace said that psychotherapy is to make the healing powers clear and systemized, which is found as a natural potential in people's verbal and non-verbal interaction. Gabbard, as author of this book called Psychodynamic Psychiatry, and he defines psychodynamic psychiatry as a way of thinking about both patient and clinician. That includes unconscious conflict, deficits and distortions of intraphysic structures, and international object relations, and that integrates these elements with contemporary findings from neuroscience. Of course, psychotherapy and neuroscience have arrived at a crossroads. How psychotherapy influences brain function, and is this relationship relevant to the work of our work, is the question mark we have in our minds. In 1895, Sigmund Freud came up with this project called Psychology for Neurologists. Here, the normal processes like memory, attention and judgment, and the abnormal ones like hysteria, repression and displacement were tackled. And at the same time, as a result of this intensive study, he sent a letter to Wilhelm Fleiss, says that scientifically I'm in a bad way caught up in this psychology for neurologists work, but then I have to break off. I have never before experienced such a high degree of preoccupation, but I was unable to continue my work, and in 1896 he stopped this work, and then he opted for another field. A neuroscientist and Nobel laureate Eric Kandel recalled this issue. If there is unconscious, what is the unconscious, and what are its neurobiological properties, and how do unconscious strivings become transformed into awareness? And they were trying to find answers to these questions, but of course they were benefiting from neuroscientific methods and cognitive psychologists. I will be talking about more of cognitive psychology and presenting data from this field. At the same time, I'll be talking about neuroimaging as well, but in psychodynamic psychotherapy, there are not much of a data in neuroimaging, and I'm going to tell you why. Functional imaging has provided the opportunity to correlate directly cognitive and emotional processes in the brain. This graphic illustrates all the studies from 1990 to 2003. And the light bars indicate medication, that is pharmacotherapy, and imaging studies. It's the number of them, and the dark ones indicate imaging and psychotherapy studies. You see that in years imaging and medication studies augment, but imaging and psychotherapy studies stayed the same. Models of psychodynamic concepts and treatments. Now, psychodynamic therapy is an individualized treatment, so it's impossible to come up with a standardized treatment protocol. However, functional neuroimaging was an important study area. PET, SPECT, and fMRI studies are important. PET and SPECT shows us the functionality of the brain during a specific homework or during rest. Functional MRI shows us the repeated measurements of brain activity, because it does not include radiotope isotope. Neural research on psychodynamic and psychodynamic psychotherapy are divided into 4 domains: memory and learning, affect, social cognition, relatedness, free association. Let me go over all these issues one by one. Now, memory and learning. What is important here is that there are important processes that take place outside of awareness, and some of them, majority of them, are actually taking place outside awareness. And for example, a person's expectation of certain responses from a caregiver may be called as an explicit memory or an implicit memory. I'm going to talk about them in detail. Explicit or declarative memory is knowing what it is actually. The processes here are conscious processes, so it can be declared or it can be explained. Implicit or procedural memory is knowing how. And the processes that are taking place are completely unconscious. For example, tying the shoelace, playing the guitar, riding a bike. So these are about how to do things rather than what they are. And sometimes they can be encoded in our awareness or conscious area. So memory can be declarative, things that you can tell others, or non-declarative, which are the things you know that you can show by doing. And declaratives are divided into 2 as episodic and semantic. That is like episodic, remembering your first day in school, and semantic is knowing the capital of France. This is a semantic. romantic example. And riding a bicycle, to have being more likely to use a word you heard recently, or salivating when you see a food. The later examples were an example of implicit memories. Explicit memories are encoded by hippocampus within the medial temporal lobe, stored in the temporal cortex. Procedural memories do have associations with cerebellum, patellum, and this is a slide for that. This is important for us because in the first few years of life, normally the things experienced, that is emotions, pieces of emotions, are encoded in a procedural manner, so they change more slowly and they are less open to verbal interpretations, and they are described as pre-oedipal content by some psychodynamic theorists. Symptoms based in neurotic conflict that develops later in life may be more symbolic despite being unconscious, and they are called oedipal material, and they are more responsive to psychodynamic treatment therapy. Affect or emotions, in other words. We have two axes here: activation, deactivation, pleasant, unpleasant emotions or effects. Here, with the impact of dopaminergic areas in the brain stem, there could be this effect, and then there is arousal, reticular formation, thalamus, and dorsolateral prefrontal cortex is impacted here. But in general, amygdala and anterior cingulate are processing these processes about effects. Psychodynamic models are concerned with how effects are generated, regulated, and expressed, and they are brought along to the conscious or awareness. Or this is another area, social cognition and relatedness. By the way, your last 5 minutes. Thank you, Mr. Chairman. I can be faster. The interphysic representations of relationships are very important. Social cognitive area is an area where developments are taking place. Transference is very important. Feston and Gabbard argue that this transference is a form of implicit memory, and some aspects of this transference are rooted in procedural memories, and within basal ganglia they change more slowly, and they are less responsive to psychodynamic therapy. Other aspects of transference are in implicit associative memories, and they are in frontal cortex and hippocampus, and they are more responsive to this therapy. Bowlby, Ainsworth, and Mate come up with this association theory. I am kind of fast here, but theory of mind, mentalization, it's an individual's understanding about the content of other people's mind, and this is in mostly medial prefrontal context. I'm not sure if you can see here, but theory of mind here is marked in yellow, as you can see here. I'm sorry, says the speaker. Mirror neurons, I think, will be touched by other colleagues as well. They are in reference to premotor and parietal cells in the brain. Primary identification is very important. That is one person associating with another mental processes of another person. This is one monkey reaching out for a banana and another monkey reaching out for the same banana, and their brain activities were observed and similar brain activities. So it is the same activity when one monkey is reaching up for the banana and when the other is watching that monkey. Free association and defense, attention, free association and defense. Repression is an important mechanism here. Motivated forgetting is in the dorsolateral prefrontal cortex. Dreams are very important, and brainstem, limbic and paralimbic circuitry and dorsolateral prefrontal cortex are the active areas during dreams. Free association, you know default mode, I think, and during free association, brain is at rest. This is assumed. But some of the studies suggested that when you are not thinking about anything and when there is no activity in the brain, even in that processes, there is this network, especially this network in the cortical regions. They are active. Here you see a medial prefrontal cortex and posterior cingulate and lateral parietal context. And so in default mode, they are active actually, these regions. So let me talk about conclusions in my last 3-4 minutes. One of the principal criticisms against neuroscientific investigations of psychodynamic therapy is that when clinician is with the patients, the clinician is not suggesting or delivering that much of a thing. But then again, in terms of cognitive functioning, affect regulation, they realize the importance of neuroscientific findings and they benefit from that and they try to complement their knowledge. In this modern era and in this era of imaging, the overall effects of psychotherapy on brain function should be also studied. Studies of how psychotherapy affects the brain can be a value to patients, but how does it change and how do different psychotherapists change brain function are those questions that still need to be answered. To date, limbic and paralimbic structures, memory systems, conflict management and affect regulatory systems, attentional systems, planning and procedural memory systems do have important psychodynamic correlations or relations. It was already found by other studies, including neuroimaging studies. Synthesis and future directions. So language, social activities, where does, which areas of brain are active. It is said that we might know the localization of individual psychodynamic processes, but this is rather hard because the brain functions in a holistic manner. So certain psychodynamic processes like memory, like transference, might be linked to a specific region of the brain, but this might be wrong as well. New paradigms are needed. Clements, a retired psychotherapy expert, psychotherapist, says that, as Wallace also mentioned, there's quite an interesting overlapping here. It says that there is this power of nature, and psychotherapy utilizes this nature's way of changing their own resources. Why? To understand the thoughts and emotion of patients and to be able to have this transformational power of psychotherapy, we must keep the psych, or we must keep the miracle of psych, or the miracle of spirit, in other words, in psychiatry. And as we try to use the knowledge of the human mind and brain, we must be able to use the resource of psychoanalysis, cognitive psychology, and neuroscience. This new paradigm might require a lengthened residency or additional fellowship years. This is interesting. My last words are, well, understanding personality development and psychodynamics is vital when taking care of a patient. Psychotherapy even when psychotherapy is not feasible or part of the treatment plan, we still have to understand these. And this was the first sentence of Goethe, and Clemens says that there is no substitute for clinical experience over months or years with many patients, because when somebody is taking care of another, and somebody is trying to understand another, he is also getting awareness of one's own inner life, and this is very